male comes to the clinic with no visible palpable swelling, but complains of fluctuance and soft bone in one side of the jaw. After taking a radiograph, you see a massive lesion extending from the center of the mandible to ramus. What could this lesion be? Let's dive into the topic of odontogenic keratocysts. Odontogenic keratocysts is a distinctive form of developmental cyst that deserves special attention owing to its specific clinical behavior and histopathologic features. One of the many features that makes it special and distinctive is the fact that it grows to a large size before manifesting clinically. The reason for this may be that it grows in the anterior-posterior direction. Another feature of this cyst is its tendency to recur, and as we discuss further, you will know why. Odontogenic keratocysts arise from the cell rests of the dental lamina and basal cell hamartias. OKC shows a few features of a neoplasm. Several investigators have suggested that odontogenic keratocysts should be regarded as benign cystic neoplasms rather than cysts. And in the latest WHO classification of odontogenic tumors, they have been given the name keratocystic odontogenic tumor. So, is it a cyst or a tumor? KCOT has been renamed as OKC in the year 1956. However, the neoplastic behavior in the cyst persists. The lesion is named keratocyst because the lining epithelium produces so much keratin that it almost fills the cyst lumen. Odontogenic keratocysts are found in a broad age range, from infancy to old age, but most of the cases are seen between the ages of 10 and 40 years. There is a slight male predilection. Mandible is involved in 60 to 80% of the cases, with a marked tendency to involve the posterior body and ascending ramus. Generally, smaller OKCs are discovered during routine radiographic examination. Larger odontogenic keratocysts are associated with pain, swelling, or drainage. As odontogenic keratocysts grow anterior-posteriorly, it may not cause obvious bone expansion. This feature helps in differentiating it from dentigerous and radicular cysts. Often, multiple odontogenic keratocysts may be present. Such patients must be evaluated for other manifestations of Nevoid basal cell carcinoma syndrome, also known as Gorlin syndrome. The other manifestations of this syndrome include multiple basal cell carcinomas, calcification of falx cerebri, fused vertebrae or bifid ribs, hypertelorism, and ovarian cysts and fibromas. Nevoid basal cell carcinoma syndrome occurs due to PTCH1 gene mutation. OKCs demonstrate a well-defined radiolucent lesion. Large lesions, especially in the posterior body and ascending ramus of the mandible, may appear multilocular. The lesion shows scalloped borders. Resorption of roots of erupted teeth adjacent to the odontogenic keratocyst is less common than noted with dentigerous and radicular cysts. Let's have a look at the radiographic variants of OKC. It has 4 radiographic variants, which were given by Main in 1970. They are replacemental, envelopmental, extraneous, and collateral variants. While replacemental type is when the OKC replaces a tooth, the envelopmental variety surrounds an unerupted tooth. Extraneous OKC is present in a region away from the teeth near the ramus of the mandible, and collateral OKC is present between roots of 2 teeth, mostly the premolars. Histopathologically, the odontogenic keratocyst typically shows a thin friable wall which is often difficult to enucleate from the bone in one piece. The cystic lumen may contain a clear liquid that is similar to a transudate, or it may be filled with a cheesy material that, which on microscopic examination consists of keratinaceous debris. No inflammatory cell infiltrate is present. The lining epithelium is highly characteristic and is composed of a parakeratinized surface, which is typically corrugated, rippled, or wrinkled. The cystic epithelial lining is 6 to 8 cells thick, stratified squamous epithelium. Rete ridges are absent. Basal cells show palisading and give a tombstone appearance. Surface epithelium at the luminal side has corrugated parakeratin. Several small satellite or daughter cysts, cords, or islands of odontogenic epithelium may be found in the fibrous wall. They can be seen in 7 to 26% of cases. Infolding of epithelium into the connective tissue wall may give rise to epithelial islands. Upon suspecting presence of an OKC clinically or radiographically, histopathologic examination confirms the diagnosis. Common treatment is enucleation and curettage. It is to be noted that removal of the intact cyst is quite difficult due to its friable lining. As mentioned earlier, OKCs tend to recur. What may be the reason? This is a favorite Viva question. Why don't you pause the video and think and recollect for a minute? The reason for recurrence is the satellite or daughter cysts that are present in the fibrous wall. Frequency of recurrence ranges from 5 to 62%. Recurrence being more common in mandibular OKCs, particularly in the posterior body and ascending ramus. Even multiple recurrences are not unusual. OKCs recur within 5 to 10 years of the original surgery, thus, long term patient follow up is very important. Some surgeons prefer ostectomy as treatment in order to remove all the daughter cysts and prevent recurrence. All in all, OKCs hold good prognosis, and carcinoma arising in OKC is a rare instance. Before you get started with another topic, don't forget to revise. The best way to do so is using a mind map. Let me help you summarize the topic in under 2 minutes using a mind map. Odontogenic keratocyst is a developmental cyst that arises from cell rests of dental lamina and basal cell hamartias. Odontogenic keratocyst has a broad age range with majority cases between 10 and 40 years of age. There is a slight male predilection. It mostly involves the mandible with a marked tendency to involve the posterior body and ascending ramus. It grows anterior posteriorly. Large OKCs are associated with pain, swelling, or drainage. Odontogenic keratocyst is one of the manifestations of Gorlin syndrome. Other manifestations of this syndrome are multiple basal cell carcinomas, calcification of falx cerebri, fused vertebrae or bifid ribs, hypertelorism, and ovarian cysts and fibromas. Histologic features of odontogenic keratocyst include a thin friable wall which is difficult to enucleate. The cystic lumen may contain a clear transudate-like material or it may contain keratinaceous debris. The lining epithelium is highly characteristic and is composed of a parakeratinized surface which may be typically corrugated, rippled, or wrinkled. The lining epithelium is 6 to 8 cells thick. Retiridges are absent. The basal cells show palisading, giving a tombstone effect. Several small satellite or daughter cysts, cords, or islands of odontogenic epithelium may be found in the fibrous wall. These lead to recurrences. Radiographic features of odontogenic keratocyst include a well-defined radiolucent lesion. It may appear multilocular with scalloped borders. The radiographic variants of odontogenic keratocyst are the replacemental type, the envelopmental type, the extraneous type, and the collateral type. Now finally, the treatment of odontogenic keratocyst is enucleation and curettage, but even ostectomy may be carried out. If you want to access such mind maps for free, log into our website and mobile app and enjoy revising. If you have stuck with me till now, I'm sure you enjoyed the video. Please do like, share, and subscribe to the channel. It makes up for all the time and effort we put in to make concepts so simple and easy for you. Hoping to see you in the next one.